Welcome. This is the Wasserstrom Family Distinguished Lecture. It's my pleasure and honor to introduce our speaker today, Margaret Brandeau from Stanford. Now, before I introduce Margaret, though, I want to say a few words about the lecture series. This was made possible by the Wasserstrom Family Endowment, which provides support for enhancing and supplementing educational experience of IEMS, that's Industrial Engineering and Management Science, students at Northwestern University. That's the Wasserstrom Family Endowment. This is part of what the endowment sponsors. And Alan Wasserstrom, the Wasserstrom family, is a 1962 graduate of IEMS. Alan is also the owner and CEO of N. Wasserstrom & Sons. He's a recipient of our Distinguished Alumnus Award, and he's a very active member of the IEMS Advisory Board. So I'd like to thank Alan and his family for the generous endowment that's made this possible. And this is also the inaugural lecture. This is going to be an annual series. This is the very first one. And being the first one, we wanted, yeah, don't mean to put any more pressure on you, but being the first one, we wanted to make something that's befitting to the occasion, both in terms of the topic area and also in terms of the speaker. And regarding the topic area, IE and OR, it's really all about improving things, taking a complex system and analyzing it and engineering it for better efficiency and better effectiveness. And arguably, or maybe not so arguably, that no single system is could benefit more from improvement than the healthcare system and public health. And also, there's probably no system whose improvement would benefit society more than healthcare. So we thought that the broad area was a very nice topic area to have the inaugural lecture in. And IEMS department is also moving more heavily into that area too, so put those together and it seemed like a good topic area. And then regarding the speaker, I surveyed our healthcare folks, we have quite a few of them now, asked, well, who's done really important work in the area, who's also an engaging speaker, and Margaret's name very quickly floated to the top by consensus, and I'm pleased that she agreed to come here and deliver the inaugural lecture. Margaret is the Coleman F. Young Professor of Engineering and also Professor of Medicine at Stanford, and in broad terms, her research is mathematical modeling and economic modeling to support healthcare decisions, public decisions. I think the title probably captures that pretty concisely, OR in public health. Margaret, her recent research has focused on applications for controlling HIV and controlling hepatitis B, and also preparedness for bioterror attacks, both of which I think she's going to tell us more about in the lecture. Margaret's a fellow of Informs and received numerous awards from Informs and other societies. And this includes the Informs President Award, which recognizes important contributions to the welfare of society. Also the Pierce Scala Prize from Informs, which recognizes research excellence in healthcare management science. Margaret's received the Presidential Young Investigator Award from the National Science Foundation. And on top of being a recognized leader in research, Margaret's also an outstanding teacher and has received numerous awards there, including the Eugene L. Grant Teaching Award from Stanford. And something I just learned about Margaret, talking with her in my office, she was called on to teach quality control, a subject that she's far from her area a few years ago. And I learned a few good tips from her on how to make it more interesting to IE students just talking with her. So I can see why Margaret's won teaching awards too. And with that, I will turn the podium over to Margaret. Welcome. And
thank you.
Please take over.
Well, first, thank you very much for having me here. It's a real honor to be here and great to see so many colleagues and meet new colleagues. So thanks very much for having me. As Dan mentioned, what I want to talk about today is how we can apply operations research in public health. And the subtext of my talk, which you will see why in a minute, is a little help can go a long way. So what I want to talk about is some of the challenges in public health as I see them. And then I want to talk about 3 examples of problems I've worked on in the area of hepatitis B prevention and treatment, HIV control, bioterror preparedness and response. And I selected these 3 areas because it's 3 different types of models, 3 very different types of problems that we're studying, and differing degrees of impact, some very successful, others we like to call ongoing. And then finally, I'd like to conclude with some thoughts about how I think we can be successful in using the tools of industrial engineering management science to influence policy. So challenges in public health. The first challenge is, as you undoubtedly know, we have limited resources. You know, for example, in the United States, we spend more per capita on health than any other country in the world, at least twice as much more. And we don't have the best health outcomes by any means. In developing countries, resources are even more limited. So we'll never have enough money to do everything we want to do. Second thing is that we don't necessarily have information about the potential impact of programs. We don't know necessarily if I have a disease prevention program for this population, we don't really know what will happen. In medicine, what the gold standard is a clinical trial. What you'd like to do is randomly divide your population into a group that receives an intervention, a group that doesn't, and track them over time and see what happens. But of course, that's never possible, never possible for many practical problems that we'd like to address. In addition, there's a lot of uncertainty about events that may occur. We may be thinking about preparing for a pandemic of influenza. We don't even know when a pandemic will occur or what strain of influenza it will be. If you're thinking about bioterror preparedness, it's not even clear if there will be an attack or with what agent or how big an attack. So lots and lots of uncertainty. So these all complicate the decision of how we should spend our limited public health resources. So what can OR-based models do? Well, I think they can do a number of things. First, as always, they provide a structured framework for thinking about well, what might be the impact of a potential intervention that I'm thinking of spending money on. And of course, being OR models, we can also capture some of the uncertainties, some of the complexities, and some of the interactions between parts of the system. So these are real strengths of OR-based modeling that can help in looking at public health investments. They allow for sensitivity analysis. There's lots and lots of uncertainty, but if you have a model, you can always evaluate what might happen if things are different than you think. And finally, ultimately, help guide resource allocation decisions. So that's kind of my broad overview of how I think we can help. And now I'd like to talk about 3 examples that I've worked on where we worked on some public health problems and tried to influence policies. So first is hepatitis B prevention and treatment. So this is a photo of Sam So. He's a liver transplant surgeon at Stanford. And a few years ago, he cold called me and said, Margaret, he came to my office and said he wanted to meet with me. He said, Margaret, I am a liver transplant surgeon, and a typical type of patient I might see is a young man who's suffering from hepatitis B. He's 30 years old, he's an engineer in Silicon Valley, he's born in China, he wasn't vaccinated against hepatitis B, and now I have to tell him that he's going to die unless I give him a liver transplant, and he may die anyway. And so what I realized is that I want to, in fact, go further back in the process and try to get more people vaccinated and treated before we get to the transplant option. And so he runs the Liver Transplant Center at Stanford University, Asian Liver Center. It's an advocacy group that's all about controlling hepatitis B. So he came to me and said, so this is what I do, and I'm interested in evaluating costs and benefits of different control policies, and I heard that you know how to do math. So I said, well, I do know how to do math, but I don't know anything about hepatitis. Is that okay? So that is how our beautiful friendship began. And this is a picture of Sam in Western China. He's been working with the Global Alliance for Vaccines and Immunization to vaccinate 500,000 children in a small province in Western China, kind of as a proof of concept. So a little bit about hepatitis. It's a chronic viral disease. Interestingly, so I didn't know anything about hepatitis. So there's 33 million people in the world about who are infected with HIV. There's 400 million people who have chronic hepatitis infection. And close to 750,000 deaths per year. It's a bloodborne disease. It's typically transmitted from mothers to their newborns or among children. They can get cuts and scrapes. It has an acute and a chronic phase. So the acute phase, the person is exposed to the infection. You can either resolve the infection, like when you get the flu and you get better, your immune system resolves it, or some people develop chronic infection, so it's lifelong hepatitis B infection. And it turns out that the chance that the acute infection becomes chronic decreases with age. So a young child, a newborn, say, whose mother has hepatitis and who is not vaccinated, the child has about a 90% chance of having chronic hepatitis B infection for the rest of their life, whereas, say, a college-age student has, if now exposed to hepatitis B, probably has at most a 5% chance of getting chronic infection. So it tends to be a problem mostly in children acquiring the infection. The good news, it's vaccine preventable. There's been a vaccine available since I think 1982. So we did 2 studies. The first was a study of hepatitis B in the United States. And the question we looked at is the cost effectiveness of hepatitis B screening, vaccination, and treatment policies for adult Asian and Pacific Islanders in the US. So turns out in the general US population, about 1 person in 1,000 has chronic hepatitis B infection. That's probably why many of you have never heard of it. It's not a common disease. But among Asian and Pacific Islanders, probably about 1 in 10 in the United States has chronic hepatitis B infection. This is partly because half of Asian and Pacific Islanders in the US were born in another country and weren't vaccinated. But nonetheless, a big health disparity. In the US, we had a number of ad hoc screening programs, like a person goes to their doctor, and the doctor may or may not screen them or treat them. And so the Centers for Disease Control and Prevention wanted to know, well, what should we do about Asian and Pacific Islanders and hepatitis B in the US? I mean, it seems like a real problem among these people. So this was our first project. So I'm going to tell you in very broad schematic terms the kind of model we use. We use a decision model. You could either screen these people or not when they go to the doctor's office. If you don't screen them, you could vaccinate them or not. If you do screen them, you can find out if they're infected with chronic infection, if they've never been exposed and they're susceptible, or if they've been exposed or vaccinated and they're immune. And then if they're immune, you don't have to do anything. If they're susceptible, you could vaccinate them or not. And if they're infected, you could put them onto treatment or not. So these are the different things you could do. The status quo, we looked at 5 policies, the status quo and 4 others. The status quo is just nothing, no formal policies. We also looked at a policy of universal vaccination. That would be saying, if such a person shows up at their doctor's office, you should always just say, if you haven't been vaccinated, I need to give you this vaccine. We looked at a policy of screening, treatment, and vaccination. So that says you vaccinate people who are susceptible, and if they're infected, you get them on treatment. It turns out that the antiviral drugs that have been developed for HIV, many of them work very well for hepatitis to control the virus and extend length of life. You could screen and treat, but not vaccinate susceptible individuals. And you could also screen, treat, and ring vaccinate. And what that means is when you find an infected person, you treat them, and then you find everyone who lives in their household and vaccinate them. So that's so-called ring vaccination. So these are the 5 policies. And then for each of these different states of nature at the end of my decision tree here, we have a Markov model of disease progression in patients. Our Markov model at a very high schematic level looks like this. You can be susceptible, get exposed to the infection, get the acute infection. You could resolve it and become immune, or you could get chronic infection. And these are all the chronic infection states. When the liver starts to fail, you get an elevated liver enzyme, in which case you might be able to put the person on treatment. They may respond and the viral load would be low, or they may not. The disease may progress to either cirrhosis or liver cancer, and potentially the people could get a liver transplant. In addition, people can die from any of these states. So this is our Markov model. Vaccination would take people from susceptible to immune, and treatment would get people from symptoms to treatment response. So that's the Markov model that goes with the decision tree. So how did we model this? We modeled this in an Excel spreadsheet. We followed a cohort of 40-year-olds through their lifetime, and then we did sensitivity analysis looking at different ages of adults. And we thought about, well, what would policymakers want to know? Fundamentally, we want to know costs and health benefits. So cost is just discounted lifetime costs of the vaccination, treatment, whatever it is, plus healthcare. And then for health outcomes, we looked at deaths averted and quality-adjusted life years gained. So that's not only how long people live as a result of your intervention, but the quality of those lives. So that's a utility multiplier of 0 to 1 on the life years. And then we can look at the ratio of costs per quality-adjusted life year gained. So this is pretty standard in health economics. So here's a schematic of what our results look like. So we have cost, incremental costs on the x-axis, quality-adjusted life years gained on the y-axis. So because this is all incremental, the status quo is at 0. So that's no formal screening, treatment, or vaccination. Universal vaccination, it turns out, will cost a bit and not gain a lot. Screening and treatment, somewhere up here. Screening, treatment, and vaccination, a little bit like universal vaccination here. It gets you a little bit, but not much, and it costs a fair amount. And finally, screening, treatment, and ring vaccination is somewhere up here. So this is a problem of really two objectives, costs and or two attributes, costs and quality-adjusted life years gained. So we first look at the efficient frontier. And so we can draw our frontier here, and similarly here. So looking at this, this says that the efficient policies would be screening and treatment, or screening, treatment, and ring vaccination, and that the policy of universal vaccination is essentially dominated. The assumption here is that these interventions are divisible, completely divisible, so you could have a very small amount of the screening and treatment and the status quo, and you'd get somewhere on this line that dominates this policy. So these policies, universal vaccination and screening, treatment, and vaccination, they're dominated. The non-dominated policies are screening, treatment, and ring vaccination. So we can remove the policies that are dominated. And then the second thing we can ask ourselves is, well, then what should we do? If these policies are not dominated, what should we do? So screening and treatment compared to the status quo costs $36,100 for every quality-adjusted life year you gained. Screening, treatment, and ring vaccination costs slightly more, $39,900 per quality-adjusted life year gain. So then the question is, well, now you've told me sort of the incremental costs and benefit of each of these things we could do. What should I do? So the World Health Organization says that interventions that cost 3 times the gross domestic product per capita in terms of cost per quality-adjusted life year gained are cost-effective, and if they cost 1 times the GDP per capita, they're very cost-effective. So the GDP per capita in the US is, I haven't looked this year, but let's say roughly $45,000. So using that criterion, these policies are both very cost-effective. So to summarize then, we found that vaccination is not cost-effective for most Asian and Pacific Islander adults. And intuitively, I kind of know that now. I should have known it in advance. Because adults are not likely to get chronic infection when they're exposed, vaccination doesn't help much. Moreover, they're not that likely to get exposed to infection because the rate of infection in the general population is so low. So now I know, but I probably could have known that in advance. It's really the only vaccination that's cost-effective is the ring vaccination of the close contacts. And screening and treatment is cost-effective. So those were our findings. So now I've told you about a model, but my talk today is really about how we can influence policy. So how do we do that? Well, first thing, dissemination and impact. First thing is dissemination. So all along the process when we were developing this model, we shared the results with the CDC. It turns out that I have a very simple mind, so I made my student do this in Excel. This is because I can't understand anything else. And this was perfect, because then we could send that spreadsheet to the CDC, and they could look and say, oh, you made those assumptions about how the disease progresses and all the things that are happening. I wonder if we could try a different number. So all along, this developed their trust in the process. The second thing we did, which I think is essential if you're trying to change public health in a lot of areas, is to publish it in a medical journal that people who set policy read. So we published this in the journal Annals of Internal Medicine in 2007. So that's the next thing we did. And in September 2008, the CDC did change their screening recommendations. So the new screening recommendations say that anyone in the US who was born in a region where chronic hepatitis B prevalence is more than 2% should be screened for hepatitis B. And obviously, if they're infected, should be treated. And anyone born in the US who wasn't vaccinated as a child, but whose parents were born in regions where prevalence is 8% or higher, should also get screened for infection. So the CDC actually pretty much took our recommendations as is and implemented them.
Margaret,
yes?
Do those percentages come out of your?
Yes, we did sensitivity analysis. We had 10% prevalence among the Asian and Pacific Islanders, but we showed that even if it's as low as 2%, you want to screen people because the benefit of finding the people and getting them onto treatment is large, so they don't die from cirrhosis and liver cancer. Yes, so that was another benefit of our model, sensitivity analysis. So this would include Asian and Pacific Islanders, plus many people from countries in Africa and other places, and much of Southeast Asia. Our second project was hepatitis B in China. This is another picture of my colleague's program to vaccinate some children in Western China for hepatitis B. So this project was to look at the cost effectiveness of catch-up vaccination for children and adolescents in China. In the US, most of our children are vaccinated. Like most children who are born after 82 or 83 have had hepatitis B vaccination. Most college-age kids have had it. But in China, the newborn vaccination has lagged. In Beijing, they've been pretty good, but in many of the rural, far-flung regions, there's been much less infant vaccination. And so the question is, maybe we could go into schools, this looks like maybe a little kindergartner, we could go into schools and vaccinate children. And it turns out there are probably 140 million children in China, and by children I mean I think up to age 18, 140 million children who've not been vaccinated against hepatitis B. And of course, that is the prime time to get a chronic infection is when you're young. And so China's CDC was contemplating nationwide catch-up vaccination, but before thinking about that, they really wanted evidence of its benefit. So we used a similar framework to address this question, but with data for China. So similar kind of decision tree, similar kind of Markov model of disease progression, but again, with data from China. And for many of the studies we work on, the model itself took about 2 hours to create, and the data itself took 6 months to get. So I'm glossing over lots and lots of hard work here that was done by my student, David Hutton. So similar kind of model, just had to get a lot of data. And we looked at 3 policies: the status quo, which is no catch-up vaccination for the children, universal vaccination, and screening and then vaccination. It turns out if you vaccinate someone who's immune or infected, it won't hurt them. So you can just go ahead and vaccinate, it won't hurt the child. But we also looked at whether you would screen in advance and then vaccinate. So what did we find out? Well, it turns out in this case, in fact, catch-up vaccination is cost-saving. It improves health and saves money. So it's a win-win situation. Highly robust to assumptions. We looked at different regions in the country that might have higher newborn vaccination rates, lower disease prevalence, lots of different things, different healthcare costs. In all cases, it was very, very cost-effective. And we found that screening before vaccination is cost-effective. Again, I should have known this in advance because the screening test costs $5, the vaccine costs $3. So why would you spend $5 to avoid a $3 test? So that's what we found in China. So again, we spent a lot of time trying to disseminate our results and convince people of the goodness of our analysis. So this is a picture of my colleague Sam at a hepatitis conference in China, I believe. So he traveled to China many times to meet with people at the CDC, people in the Chinese government. We published our results also in a medical journal that's highly read, in this case, the journal Hepatology. And in April 2009, China changed its policy to provide free catch-up vaccination to all children up to the age of 15. So we're talking about more than 100 million children now getting free catch-up vaccination. So in terms of OR impact, that's pretty awesome. We estimate that such vaccination will probably prevent maybe 70,000 deaths and save almost $1 billion in healthcare costs. Additionally, turns out discrimination, people who have chronic hepatitis infection in China, there's a lot of discrimination, school enrollment, employment. So if these children can be saved from infection, it also reduces the social injustice. And it's, also a model for countries with other high hepatitis burden, like Vietnam, various countries in Southeast Asia. Yes?
You mentioned there is some risk of contagion, and that probably wasn't in your model, was it?
No. We just assumed constant incidence. We assume you had a constant chance of acquiring, of being exposed acutely to the infection every year. So we assumed that any vaccination efforts or treatment efforts would not affect prevalence in the population. Turns out in China, about 7.5% of the entire population's infected. So even if you vaccinate a certain number of children, it probably won't change too much the incidence in the short term. It will change it, but we made the simplifying assumption that incidence would remain constant. Either way, it's cost saving. Well, in this case, this was China CDC, and it was cost saving, so it didn't matter. But in the US case, yes, CDC was fine with that. Yeah. So that's our work in hepatitis. So decision model, decision tree with a Markov model. Now I'm going to talk a little bit about HIV control. So the HIV epidemic, this is a global map showing the number of people infected, estimated number of people infected in different regions of the world, and sensitivity around those estimates. The basic idea, we have, say, 33 million people infected right now and lots of new infections all the time. Funds for prevention and treatment are far, far less than the estimated need. So here's some of the policy questions. There are 2.6 million new infections occurring in the world per year. That doesn't sound like a lot until you break it down. That's 7,000 people every single day acquiring HIV infection in the world. And so the first question then is, well, we have all these new cases. What programs should we invest in to prevent the spread of HIV? It also turns out, as you know, undoubtedly, we have life-saving drugs that save people's lives. They don't die now. So really great if you can get on the treatment. But 70% of eligible infected individuals in the world aren't getting treatment. Only 30% are, or about a third maybe. And so we have scarce treatment funds. How should those be allocated? But more than that is an even more important question. In the last decade or so, we've had a huge push to get people enrolled in treatment, particularly in sub-Saharan Africa. But it turns out that for every person that's been newly enrolled in treatment, probably 2 new infections have occurred. So that's a completely unsustainable system. So the question is, then what is the appropriate allocation of resources between prevention and treatment? So these are some of the broad questions we've been thinking about in HIV. Our work's been funded for a long time by National Institute on Drug Abuse, and then last year I was on sabbatical working for the United Nations AIDS program to learn more about some of the policy questions. So when we think about, so this is my little plug for OR models about what programs to invest in. That's the same map you just saw, but color-coded. So darker regions just showing higher prevalence. So epidemics are dynamic, so they change over time. They're nonlinear because the rate at which infection occurs at a very, very high level is a product of the number of people who aren't infected multiplied by the number of people who are infected. So it's a nonlinear system, and they're certainly stochastic. So nonlinear, dynamic, stochastic system. So I don't know if you can see that very well. That's a textbook on epidemic modeling. So epidemiologists are really great at modeling epidemics, but they tend not to focus so much on decisions. Now over on the right here, I've got a textbook of health economics. And I think that health economists are great at focusing on health policy decisions, but maybe not so much on modeling complex systems such as the HIV epidemic. So I think that's where OR can play a role. We know how to model complex systems, we know how to optimize, we know how to focus on decisions. So that's kind of, in my view, the role that OR can play in looking at some of those questions I just posed. So they can look at the consequences of interventions, just, simulate the system and see what would happen, costs, health effects. You can think about, well, should I invest in this program or not? You can look at single programs or portfolios, so resource allocation question. Often we don't have data, so you can think about, well, even if I don't have enough data, I can do sensitivity analysis and see if my decision is still justified. And one thing we say to people over and over again is making no decision is the same as making a decision. So you may choose not to invest, but that too is a decision. So we'll never have perfect data, and you still have to make a decision now. So I'm going to talk about 2 projects we've done. The first is on HIV in Russia. Our research group in the last decade or so has actually gone to Russia 6 times. And this is a photograph of an AIDS patient in Russia. And from this picture, you can probably see that he's probably not getting a lot of very sophisticated care. Typically, what patients get is just palliative care. You know, you have pneumonia, let me give you something for it. Very limited treatment for HIV-infected patients. So turns out the epidemic in Russia and Eastern Europe, although it doesn't have the prevalence of the epidemic in Africa, rapidly growing, the highest incidence in the world in Eastern Europe. So the highest number of new cases per unit time. Typically, much of it is fueled by injection drug use. After the collapse of the former Soviet Union, a lot of injection drug use. That's the perfect way to give yourself HIV, is inject with a needle that has HIV on it. Very minimal funds for prevention and treatment in Russia. Limited access to HIV treatment, which I've abbreviated ART for antiretroviral therapy. And at the time of our study, there was significant scale-up of treatment programs from international donors. So the question we looked at was, well then, if we're going to scale up treatment in Russia, who should receive treatment? When we went to Russia, we found out that about 1% of people who weren't injection drug users who were eligible were getting treatment. So I mean to say 1% of infected non-injection drug users were getting treatment. And really no injection drug users in Russia were getting treatment. Why? And these are quotes I heard from officials in Russia. They're criminals and they won't take their medicine anyway. So we thought, well, that was interesting. So why don't we look at strategies that target the non-injection drug users? That's kind of their current policy. Maybe strategies that just target injection drug users, or strategies that target both groups. So we decided we'd look at all these different combinations of strategies. To do so, we used the nonlinear dynamic model, basically a so-called compartmental model with nonlinear difference equations that we, again, implemented in an Excel spreadsheet. I do know how to use other things, but anyway, Excel spreadsheet. And then again, we spent a long time. We spent 2 weeks in Russia meeting people all over the country to get demographic behavioral cost data, lots of it unpublished. We then simulated our model to estimate the costs and health benefits from each treatment policy. So let me just show you a schematic overview of our dynamic compartmental model. We considered injection drug users, and we had 4 disease stages: HIV uninfected, HIV infected but no symptoms, HIV infected but symptoms, and HIV infected with AIDS. So this is basically the progression of the disease. So people can become infected and then the disease progresses. These are individuals who are not receiving ART, the antiretroviral therapy, and then some of them who either have symptoms or AIDS, so they're eligible for treatment, could get treated. So we have flow into these compartments. And then we have the same thing for non-injection drug users. So we have injection drug users and non-injection drug users. We have death from any compartment. Now, what I've got buried in here behind this little arrow is the nonlinear dynamics of this system. The rate at which uninfected people become infected is a function of their contacts. We had both sexual contact and needle-sharing contact. So it's their sexual and needle-sharing contacts with other injection drug users and their sexual contacts with non-injection drug users. So there's nonlinear dynamics buried in here. It's not shown in the picture. But so this is a model that we simulated. And one other point I want to make about this, it turns out that treatment is also a form of prevention, because individuals who receive the antiretroviral drugs have a lower viral load and thus lower ability to spread the disease to other people. Yes?
The HIV positive asymptomatic.
Yeah.
Does that mean that there's nobody that knows that they have HIV but is asymptomatic and could be treated?
to become eligible for HIV drugs, the disease has to have progressed enough. We just called it symptomatic. We have a more sophisticated modeling under here. But basically, at the very beginning of infection, the first 5 years or some such thing, the people do not get treated. Actually, in the US, we're now looking into treating people immediately when they become infected or within a year. But at the time of this study, you certainly wouldn't get treated for 5 or 6 years at least. Yeah. So this is the nonlinear dynamic model, which we simulated. You can't possibly solve that analytically. Again, we're using the cost effectiveness framework. Here's the status quo. Here's targeting only injection drug users for all the new treatment slots. Here's targeting only non-injection drug users. That's our current policy. And here's just giving treatment to people regardless of whether they're injection drug users or not. And one thing I want to mention is when we talked about strategies that involve treating injection drug users, we assumed they had extra costs because, you know, they're criminals, they won't take their medication. We actually assumed $500 extra per year to get them to take their medications. But this is what we found out. So clearly the most efficient policy, the most cost-effective policy is to only give the drugs to injection drug users. Well, of course, that is completely never going to happen because they're criminals. But it will never happen. So we remove that from consideration. But still, it's a good policy to at least think about. So certainly not in any way politically feasible. But you do see here that, in fact, the policy of giving the drugs to anybody, regardless of their HIV status, is the dominant strategy. It dominates the current policy. And the cost per quality adjusted life year gained is $1,800, well below Russia's GDP per capita. So very cost effective. So the insights from this analysis then is that the current strategy, where they're ignoring injection drug users, is the least effective and least cost effective strategy. Strategies targeting IDUs can be cost effective. And strategies expanding ART, they should really include both injection drug users and non-injection drug users. And by having a dynamic model showing all the mixing, we're able to figure out these effects. To disseminate this, we published in a major AIDS journal, actually, the journal AIDS, in 2006. We got the article translated into Russian. We had several visits to Russia to present our results. We gave out our Russian version of our paper to many people. I didn't quite throw them out of the airplane over the stadium, but it was pretty close. You know, I brought papers, you have to take them. We did present our results. And as for impact, we don't know. I think this is an example where the policies are very political, and it's going to be a long time, if ever, before policies change. But we did provide this scientific study, and we hope that eventually it will have impact. The second HIV project I want to talk about is the work I did at UNAIDS last year that I'm still doing with my graduate student, Sabina Alistar. So I showed you a model just there, a dynamic model. We thought, well, what if we could come up with a model that allowed you to, in your own country, think about how you should allocate HIV resources between prevention and treatment, or between different prevention programs? And what if there's a simple model you can use? So my grad student told me that if you want to have a model, and grad students pay attention, it must have a good acronym. So she actually spent a whole day thinking about this, but it was good. REACH model, resource allocation for control of HIV. So now at UNAIDS, they're all talking about the REACH model. But anyway, our basic idea is that it's designed for country-level planning, and it's intended to provide decision makers with broad insights about how they should spend their money for HIV prevention and treatment. So some of the features, it's a spreadsheet that's customizable to different countries. We've got hidden in the back the nonlinear epidemic dynamics at a very high level, country level. We have a number of HIV control programs, both treatment and prevention. We actually allow for economies and diseconomies of scale of programs. If you spend twice as much on prevention, you don't always get twice as much behavior change. So we allow for economies and diseconomies of scale. And we similarly capture program synergies. If you have two prevention programs, they're not going to have the same additive effect. It'll be sub-additive. We allow investment analysis. So we have what-if analysis where the user can say, here's how I think I should spend my money. And then the model will tell you, here's the health outcomes that will be achieved. And we also, in the background, we numerically calculate the optimal portfolio given the constraints set by the user. So we've done some beta testing of the model. We've implemented it for 4 countries. So what do we find out? Well, not surprisingly, the current portfolio of investments that a lot of countries have, probably really not optimal. There are countries where no money is spent on men who have sex with men, prevention to that group, yet you know that that's a big driver of the epidemic. So even without a model, we know that. But the model shows that for a lot of times, scaling up what you're currently doing may not be the best thing. The objective function choice matters. At UNAIDS, they tend to talk a lot about HIV infections prevented, and you can read their stuff on their website. It's about we prevented this many infections. But quality-adjusted life years also matter. So if you're talking about infections prevented, you want to spend money on prevention. If you're talking about quality-adjusted life years gained, you want to spend money on treatment. So our model allows you to look at different objective functions and see how you want to spend the money. Length of the time horizon matters, short-term planning versus long-term. How you spend money on the different risk groups can significantly affect outcomes. And certainly the best allocation differs by setting. So different countries have to implement the model. So we're currently working with planners at UNAIDS. We have REACH version 2 we're working on right now. We're refining the model, beta testing it with some country level planners next, applying it to more countries. And our eventual goal is to post it on the UNAIDS website. So that's how we envision this model. And we've written an article about this that'll be coming out. So this is work we're doing in HIV. Again, I think the impact is ongoing. It's not like the hepatitis where we could say 150 million children are now getting vaccinated. But I think slowly but surely we will have impact in this area.
Margaret?
Yes.
What are some of the things that, so it's customizable by country.
Yes.
What are some of the things that differ by country?
Who the risk groups are. In sub-Saharan Africa, the way HIV is spread is all heterosexual. In Eastern Europe, there's a lot of injection drug users. The US, a lot of more men who have sex with men. So it's about who the risk groups are. It's different prevalence, different incidence, different interventions that are available and acceptable in different countries. So in Russia, a lot of injection drug use is causing the spread of the HIV epidemic. But methadone maintenance, which is a great way to treat injection drug users, or at least get them from not injecting heroin, is illegal in Russia. So political constraints, social constraints, funding constraints. So lots of differences between countries. So our goal is to help planners in countries develop broad insights. And so got to stay tuned for how this one turns out. I don't know. The third area I want to talk about is bioterror preparedness and response. Here's a poster. Anthrax. A round of well-placed shots will stop this killer. Anthrax bacterium. No cloud, no odor, no smell, no boom or bang, just death. So the United States government has identified 12 threats, bioterror threats, different agents, anthrax, smallpox, botulism toxin. There's a list of 12. And right near the top of that list is anthrax. So it's viewed as a major bioterror threat. Turns out if you breathe the anthrax spores and you don't get any treatment, you pretty much will die, just uniformly fatal. So the way the disease works, it has an incubation period with a median of 11 days. You've got no symptoms. You maybe don't know you breathe the spores. You just think you're fine. Then the person develops so-called prodromal infections like the flu, lasts 4 or 5 days. Then so-called fulminant infection lasting 1 or 2 days. Fulminant infections like very, very serious respiratory distress followed pretty much immediately by death. So it turns out that anthrax can be treated with common antibiotics, ciprofloxacin or doxycycline, which are found in every pharmacy and hospital. Very common, inexpensive antibiotics. But the catch is that people must receive treatment while they're in the incubation period, if at all possible, because the chance of surviving when the symptoms have developed is extremely low. So the federal government worries a lot about anthrax. Here's an example of how things would work. So there's some kind of bioterror attack. In my little picture here, there's a plane spewing out spores over the stadium. And there are people in the population who are exposed or potentially exposed. you don't know if you've breathed the spores. They're invisible. It's hard to test for it. So anyone who's in the vicinity is potentially exposed, and some are truly exposed. When this happens, people would go to local dispensing sites. I've shown a picture of a school. All communities, like the Chicago metropolitan area, has plans for what would happen if there were such a bioterror attack. And lots of schools and other firehouses and other places are going to be local dispensing sites where people would go to get the antibiotics. So where do these antibiotics come from? Oh, and if they're sick, they'd be put in the hospital. Where do these antibiotics come from? Well, from local inventories, your hospital, your pharmacy, your nursing home, if there's any local stockpiles, as well as the so-called strategic national stockpile. This was created by the federal government, basically in response to the 9/11 terror attacks. We decided we'd have a federal repository of supplies for response to any type of terror attack. And that's called the Strategic National Stockpile. It's administered by the Centers for Disease Control and Prevention. Has two parts, push packs. There are 12 jumbo jets that are fully loaded in undisclosed locations. Can't say where they are, but they have millions of doses of antibiotics and ventilators and potassium iodide, lots of things. And then there's also agreements with pharmaceutical manufacturers and equipment manufacturers to provide inventories in the event of some sort of attack. So that's how the process works. And the question is, to what extent should local communities hold inventories of antibiotics for anthrax response, and should these antibiotics be stored in every home? This is the question that was posed by the federal government, and they created a committee of the Institute of Medicine that I was on to try to figure out the answers to these questions. So you can see it's kind of a supply chain question. There's the national level inventories, local inventories, and perhaps intermediate level inventories as well. So one more thing, the anthrax response timeline. An attack occurs. It's going to be a little while until we detect the attack, so there's surveillance systems, unless the terrorists tell us about the attack. There's laboratory confirmation. Once we know it's anthrax, there would be an order given to dispense antibiotics to the public. Inventory is deployed, and then once the inventory reaches those dispensing centers, dispensing would begin, dispensing happens, and then everyone's received dispensing. So that's a timeline of what would happen. Just in this picture, you can see that the minimum time to receive antibiotics is the time when dispensing begins, and the maximum time is the time when dispensing is completed. So the question in this timeline then can be phrased as, to what extent should we preposition antibiotics to try to reduce this timeline? So here's a picture of what the system looks like. There's the Strategic National Stockpile with the push packages and vendor-managed inventory. In addition, a number of states have stockpiles. Again, we're trying to help the federal government with this, but this is all highly classified, so you don't actually get numbers about where the stockpiles are or what's in them. But nonetheless, states do have stockpiles. There are also local inventories. I know in Palo Alto, I think our local VA hospital has a pretty large inventory of antibiotics in the event of some sort of an attack. Other communities don't have anything. It just depends. But they're probably local inventories. Then when an event occurs, these antibiotics would be sent to a distribution center, so-called receiving stage and storing, and then eventually to the points of dispensing. So these are the dispensing center. There's two types, open or closed. Open means like at the schoolhouse, and closed would be like at a large employer, or everyone who worked for Northwestern University. And so people would come and get the antibiotics. So you can think about prepositioning in this picture. So there's a strategic national stockpile we already have. And the question is, should we forward deploy and have some inventories in our community? Should we, they call it caching, should we have the inventory at the points of dispensing? And you could even think about, should these antibiotics be in everybody's medicine cabinet? We call that pre-dispensed. So that was the question the federal government was asking. Should we push it all the way down to your medicine cabinet, these antibiotics for anthrax response? So to analyze this question, we did both qualitative and quantitative assessment. So qualitative assessment, and I think a lot of you who know about inventory theory, this is probably kind of obvious, but when the risk is high and you don't have much dispensing coverage, then presumably prepositioning may make sense. If you live in the middle of Iowa, you probably don't need antibiotics for anthrax. You live in Manhattan, maybe prepositioning makes sense. So certainly has to do with the risk of an attack, whatever that risk may be, and your ability to dispense. As you move the material further down the supply chain, well, closer to the end user, so maybe the health benefits would increase because people could get the antibiotics more quickly. But of course, costs will increase because now your inventory is less flexible and you've got more of it. And potential for misuse could increase, for example, if it's in everyone's medicine cabinet. So that's the qualitative assessment. But we also did quantitative assessment. We looked at costs and health benefits. So costs, we looked at initial and ongoing inventory costs. And benefits, we looked at how long it takes to receive prophylaxis and then translating that time into chance of survival. So let me tell you how we did assessed costs and assessed benefits. So how we assess costs, we outsourced it. We hired some consultants to do this. That's how I did it. Let's be honest. This is for the Minneapolis Metropolitan Statistical Area. We hired a consulting firm to figure out how much it would cost us with the current system of no prepositioning. What about if hospitals and pharmacies in the area had enough inventory to serve 20% of the population? What if instead workplaces like large employers, I think like Honeywell's there and whatever, large employers, 3M, had enough inventory to serve 20% of the population? What if everyone had it in their medicine cabinet? And then for each of those, they looked at initial costs of purchasing the inventory and various annual costs. So you can see that the inventory purchase cost is about the same for when you want to have it in workplaces or hospitals, but huge if you want to put it into everyone's home. In addition, I didn't mention this, but you may know this, antibiotics expire. The antibiotics will probably expire at the best case in 2 years. They have to be rotated out. So every year you've got to purchase new antibiotics. But that isn't true for the case of hospitals because they can just rotate it back into stock. But if, say, IBM were keeping enough inventory to serve however many people, they'd have to, every year or so, have to replace that. I guess here they're having annual replacement. And similarly in your medicine cabinet. So really expensive. And then you can also think about inventory management costs, and then they have some personnel training costs, which would mostly be for workplaces. But this just gives you a sense of the cost, and you can certainly see, whoa, putting it in everyone's medicine cabinet, that is astoundingly expensive. So then the question is, okay, so we have some sense of the relative cost for one area and showing how you could do it. What about the benefits? What kind of health benefits? So let's get back to this picture I showed of the timeline. So what we'd like to know is, as a function of how long this takes, we'd like to know how many people have not yet developed or not yet developed symptoms, because the ones who haven't developed symptoms are the ones we can save. But we don't exactly know the survival curve for anthrax. You can't do experiments on people and give some people anthrax and some not. But it turns out in Russia, the Sverdlovsk weapons facility had an accidental release of anthrax, which was covered up by the KGB, but later scientists did go and find out what happened. So there's a bit of an estimate of what this curve looked like. It's something like this. And this is the percent of exposed people who've developed symptoms. So the ones who haven't developed symptoms, these are the ones we can save. So that would be the maximum fraction we could save, and that would be the minimum. So to analyze this problem, we can put a little notation in. We'll call this f of t, the fraction you could save. This is the delay until you begin dispensing, and that's how long it takes to dispense. So we can just do a little easy math here. So if we assume dispensing happens uniformly over this time g, then the probability a person gets dispensed at any time is 1 over g. We can also, it turns out, although we don't know what this curve is, a good estimate is 1 minus e to the minus 0.004t, which can be approximated as 1 minus 0.004t squared. So simple formula. Oh, well now we can figure out how many people are saved. We can just integrate if you assume uniform dispensing. So you can work that out, get this nice little formula. So this is a formula as a function of the delay delta and the dispensing time g, and a couple of numbers. So that tells you the fraction of people saved. So simple, nice formula. So we worked this out. We didn't have consultants this time. We did it ourselves. So we figured out the fraction of exposed individuals saved. So we've got no prepositioned caches that would serve everyone in the population. and pre-dispense in your medicine cabinet. We assume that the current system can dispense in 48 hours, so the government claims. If there were workplace caches, they could, because it would be distributed in your community, everyone could get their antibiotics in 12 hours, and if it's in your medicine cabinet, 0. That isn't true because you're not home all the time, but let's just make it 0. And then we looked at the delay until you detect the attack. So maybe in the best case, the terrorists announce it 24 hours, and you could see it makes no difference if there's pre-dispensing. As the delay increases, it makes more of a difference as you pre-dispense. But one thing you notice here, there's not a big difference between caches and in every home. So this just gives a flavor of what the costs and benefits might be. Highly schematic, it's based on classified information, and this is just assuming an attack occurs. We don't even know if an attack will occur. So nonetheless, it's a way to think about the problem. And then finally, we recommend a framework where, again, you think about costs and health benefits. Presumably, as you increase your prepositioning, it costs more, it gives you more benefits, and maybe it would look something like that, the different strategies. And then you could figure out, well, what's the efficient frontier? So this is the framework that we developed for thinking about this problem. So we wrote an Institute of Medicine report. Oh, and so some of our findings. So basically, the best strategy depends on lots of things related to the local community. Pre-dispensing, super expensive. Forward deployment and keeping in local caches may make sense in some places. So our Institute of Medicine report was issued in September 2011. Our committee had briefings with the Centers for Disease Control and Prevention, Department of Health and Human Services, congressional staff, et cetera. We were pretty excited. We were on CNN. So that's, not often your OR modeling makes it to CNN. As for the impact, I think that trying to change governmental decisions is like trying to change the course of a battleship. Maybe we nudged it a little bit in a different direction. Although I will say that as a result of this committee, I did get appointed to a federal committee that oversees all preparedness activities of the Centers for Disease Control and Prevention. So maybe that's where the impact's going to be, is like sort of getting onto a higher level policy committee. But anyway, so this is my third example. I'd like to conclude by giving you my thoughts on successful analysis. So what have I learned from all this? Well, when my children were young, I have 3 sons, and I used to read them this book called Tough Cookie. And it was about this cookie named Tough Cookie. Life had been hard. He was at the bottom of the cookie jar. And he's this hard-boiled detective. And this is his friend, his mall, Pecan Sandy. And somebody was stealing the cookies from the cookie jar. And Tough Cookie had to figure it out. Finally, Tough Cookie figured it out. It was Fingers. Fingers was stealing the cookies. So she says to him on the last page of the book, "You're one tough cookie. You don't learn fast, but you do learn." And sometimes I feel that way after I finished an analysis. It was like, I should have known that in advance, but now I know it. So what have I learned from the various analyses that I've done? So some elements in hindsight of a successful analysis, I can't emphasize this enough, is to pick a real problem and an important problem, a problem that people really care about. I found that you can do a wonderful analysis, but if no one cares, it makes no difference. But if you pick the right problem that people care about, even if you just do a good/okay analysis, people will care about what you did. I think the second one, which you probably noticed from my talk, interdisciplinary collaboration. As an operations researcher, I didn't know what hepatitis was. I didn't know anything about anthrax and prepositioning. So interdisciplinary collaboration is essential. Well, from the point of view of an engineering professor, I think, and for students, I think a really important thing is that there be a mix of theory and application. So it's not just consulting work, and it's not just theory. It's sort of, you're applying something new. You're solving a new problem that has some new theory in it. Again, can't emphasize this one enough. Focus on identifying good policies, not on developing sophisticated models. Time and again, people say to you, can you just tell me in 2 sentences what you found out? And so you kind of have to be ready with, well, this is a bad policy and this is a good policy. You could get a little more sophisticated than that, but identifying good policies. And finally, disseminating results to policymakers. It takes a long, long time, and that's why you saw for impact on some of these, I said question mark. It's a long time to influence policy. It's an ongoing process, but I think a valuable and rewarding process. Finally, this is a picture of some lovely citrus fruit. I don't know if you can tell, this is low-hanging fruit. I think that public policymakers need our help, and we have a lot to offer. So that is what I have to say about OR and public health. Thank you. And that's Stanford. Yes, Dan?
The solutions always depend on a lot of variables.
Yes.
Many of which are not known with high certainty. I know you did sensitivity analysis, but are there other things? Some statistical analysis where you put distributions on everything and look at variances?
Yes, I glossed over lots and lots and lots of years of work here. But yes, we do sensitivity analysis. We do one-way sensitivity analysis. We do multi-way sensitivity analysis. We do stochastic sensitivity analysis. In stochastic sensitivity analysis, we'd assign different distributions and sometimes make things be correlated, like if costs go up, they should all go up or whatever. So yes, lots and lots of sensitivity analysis. And sometimes we find out if this is not the way you thought it would be, then this is not a good policy. So in the case of hepatitis in China, pretty much all the assumptions we looked at, it was still a great thing to do. But that's not true of everything we've looked at. Yeah. Yes?
And a question on your, they're all criminals
Yes.
problem. So did you look at the possibility that investing in, looking at your model, investing in prevention for intravenous drug
Right.
users would actually increase the results for non?
Right.
Because if you could
Right.
show that investing in this would actually increase the
Right.
results for, were you able to do that? Or?
We didn't do it in that study, but we published a study last year on HIV in Ukraine showing that treating injection drug users, like getting them into methadone and getting them to stop injecting drugs, actually helps the rest of the population enormously. So yes, they're criminals, but you don't want those criminals giving you diseases. So yeah,
It seems like
yeah.
you could
So
use
in
it
a,
that way.
yeah, and that's the beauty of a complex model that captures all the parts of the system. So in a different study we did that. Yes, Barry.
So you seem to have been remarkably successful at getting policymakers to pay attention to results from models.
Right.
Any general insights about that?
Yes, it's to pick an important problem. It's to work with a domain expert. So I worked with Sam So from the Asian Liver Center at Stanford. It's his life work to change hepatitis policy. It's his life work to control that disease. Or maybe not his life work because he's also a transplant surgeon, but it's a really important part of what he does. And although I didn't mention it, he got me onto an Institute of Medicine panel on controlling hepatitis in the United States. So I think it's to work with collaborators who are very interested in the policies, and he had the ties to the CDC. In the case of HIV, I decided I would go on sabbatical to UNAIDS and start making those connections, and that worked out well. So to work with people who have some policy expertise, if possible, is helpful. I think the second thing is to be able to say in very plain English what your work is about. I work with a physician at Stanford who's a very, very smart guy, and he's a professor of medicine and famous guy. But he always says to me, I'm not very smart, Margaret, and I need you to tell me in 2 sentences what this is about. Or he'll say, that's not interesting, and that is. So to talk to someone, say clinical, if it's a clinical study you're doing, that can really say, that is interesting, that is not interesting, because I don't always know what is the most interesting aspect of a problem. So I think also domain expertise is important. And then I think the third thing, if you're trying to publish in a medical journal, you got to have all the math in the appendix. Like you can, okay. I mean, you can use the word Markov model maybe, but not much else. Yeah. Yes.
To what extent do you examine the micro incentives of your policies? So, for example, if I want to treat intravenous drug users, this might incentivize some non-intravenous drug users to become intravenous drug users to receive HIV treatment.
You could, well, I hope not. We've actually thought about that. An example is people who get onto HIV treatment. So do they act more risky now that they know they're less infectious or not? And that is, so sometimes you can use sensitivity analysis to investigate what may happen if the behavior you're imagining comes to place. it turns out when people get on treatment, there's mixed results. Some people say they're more risky, some say they're less risky. I think it's probably a wash on that one. But the example you mentioned, you could model that if you wanted to. But often what we'll do is after we've done an analysis, then qualitatively at the end of the article, we'll say things like, we assumed homogeneous mixing, but in fact people really mix in networks. You know, you only mix with your friend. And to the extent that you could target people in the center of the networks, you'd get better results. Or so sometimes we handle those qualitatively. But I think it's important to at least acknowledge them, even if you can't model them.
Thank you very much, Mark.
Thank you.